Good morning and welcome back. You're still watching Daybreak on this 12th day of April 2021. My name is Sam Gituku, just in time for the discussion on state of COVID-19. Of course, the response that you've seen and the challenges they are in. We are joined by Professor Joachim Osur, who is the Technical Director at AMREF Health Africa. Good morning, Prof.
Morning.
We also have Dr. Victor Ngani, who is a critical care doctor, but also the Group Medical Director at RFH Healthcare. Good morning, Dr.
Good morning, Sam.
Right, and we'll be joined shortly by Moses Kajwang, who is the Senator of Homa Bay County, as well as Dr. James Nyikao, who is the Member of Parliament for Seme constituency and also sits at the Health Committee of the National Assembly. But before we do so, there are some statistics I want us to look at just briefly to tell us about the situation that you're witnessing. Do you have those numbers? This is COVID-19 in the country, and the numbers are the total infections at the moment are 145,670 total infections reported, and the positive cases as of that was reported yesterday were 486 out of a sample of about 4,134, meaning that the positivity rate is at 11.8%. Prof and Dr. take note of that so that we see whether there has been any significant change in terms of positivity rate. The fatalities reported in the previous 24 hours was 18, leading to the total fatality to 2,348. And over the past 7 days, we've had fatalities of up to 124 that have been reported. Is the highest level of death in the year 2021. Then hospital admissions at the moment are 1,660, and out of this, 256 are in ICU. What those figures don't tell you is that another 257 are on supplemental oxygen, whether they're in HDU or the general wards. So that's just a sneak peek to what the situation is like. And let me begin with you, Professor Osur. When you look at the trends and the numbers that you're witnessing, you see that positivity rate reducing to 11.8%. I don't know that there's sufficient data to show that there's been any significant change, because as we began the month, we were at nearly 19%. You remember that even when the president was making the announcement of the partial lockdown in the 5 counties in the DIZ, he said that at that time our positivity rate had come up to 22%. Can we start saying that we're starting to make any gains, or is it just one of the statistics in a big pool?
Yeah, thank you. It is too soon to say things are improving, and this is because of the way we are doing the testing. The testing is not randomly done or done en masse. People are going to test because they have symptoms or because they are traveling or for other reasons. So it is not what I would call a representative sample of what you have in the community. And so today you might find that the positivity rate is 11.8. Tomorrow you might find it is 20. So we need to consistently see reduced positivity rates over a number of days before we can conclude that it is coming down. I think it is too soon to say that things are improving.
Right, too soon you say, but Dr. Victor Ngani, of course, when you look at the numbers, they've just been flip-flopping between, the lowest has been, I believe, 460, which was on the 5th of April. But as Prof says there are a number of people that are getting tested, because on that date, only 2,753 had gotten tested. But since the announcement of the revised measures by the president, you'll find that the highest level of testing has been 11,352, which was on the 8th of April. But then again, you look 2 days later, it went down to 4,134. Does this say anything about our testing strategy, or is it about the security of the testing reagents that we need? Do we have sufficient supply to sustain a sort of stable level of testing?
Well, thank you, Sam, and thank you, Professor. I think the clear thing we've seen as a country is that our testing hasn't been nearly as much as it should be. Even 10,000 a day is on the lower side. And so if we decline in the middle of a wave from 10,000 to 4,000 or 2,000, then there's cause for concern there. There's a second kind of testing that you're doing, what is called the rapid antigen. And it's good to know whether these tests are actually included in the daily count, because the rapid antigen tests, I know facilities are doing, single facilities are doing close to 30 or 40, and this is for hundreds of facilities across the country. I wanted to just put in something about what we are seeing called the positivity rate. And before this wave became clear to everybody, I think the interest in COVID-19 in the public had sort of waned, and we had fewer and fewer people coming for testing voluntarily. And so the people we ended up testing were those who were genuinely sick, whom the doctors actually had almost made a clinical diagnosis of COVID-19. And so if you are to test people who are very likely to have COVID-19, the rates, positivity rates are going to be quite high. And this is why we are seeing rates of over 20%, 26%. And now as the public becomes increasingly aware of the impact of COVID-19 in society, then more and more people are going to get tested, not because they have symptoms, but because they've been exposed or they've been in close contact with relatives, or because they're anxious. And as a result of this, you'll see a bigger pool that will test negative, not just because they don't have COVID-19, but also because they're symptomatic, their viral load could be low, and then they also have the false negatives. So this is one of the things that we're seeing contributing to the lower rates. But then in absolute values, 11% positivity rate is still quite high. 11%, 14%, these are really high rates. If you remember, start of this year, we were doing less than 4% positivity rate. So we had we're actually still having very high rates of positivity. It's important for us to note that this doesn't mean we are anywhere close to being out of the surge. These numbers, they are based on how many people we've tested, and they're based on the sampling. And the sampling is not scientific, as Professor said. The sampling is pretty much, can we say, ad hoc, and it's therefore difficult to compare the rates you're seeing 2 weeks ago and what you're seeing today.
And probably if you can speak from a point of view of being at the front line here, the people that come to your facility for testing, are they mainly the ones that are having some symptoms, or are we seeing contact tracing taking effect, like was the case at the start of the pandemic?
Yeah, so what we saw at the beginning of March this year was as the situation where we were actually almost forcing people to get tested because the symptoms were very like COVID, and very few people were accepting to get tested unless now the symptoms are overwhelming. And in that case, then the positive rate was going to be very high. But as the weeks have gone by, actually, certainly within the last week of March and the first week of April, we are seeing more and more patients actually say, I want to get tested. I think I've been in contact with someone who had COVID-19, and the whole family comes in and says, okay, let's get tested. So this is what we are seeing. It's a little bit broader in terms of acceptance. It's broader in terms of awareness and in terms of voluntary testing. And this will therefore mean that our positivity rate goes down. It's still not as low as what is reported by government. The rates are quite high, but you can understand why you'd see a lower positivity rate as time goes by, as more people come out to be tested.
Okay. And Dr. James Nyikal now joins us. He's the Member of Parliament for Seme constituency, but also a member of the Health Committee at the National Assembly. And Dr. we are talking about the rate of testing and the strategy that we have now. And I had asked that question to the two gentlemen about when you see that on a single day you're able to test up to 11,000, but another one within the same week you've tested just about 2,923. What do you know about the stock of testing reagents and the broader strategy of testing being deployed by the Ministry of Health and the different counties?
Well, I don't know the stock of the testing reagents they have, but as my colleagues have said, I think the testing is not community testing. I think we are doing voluntary testing and also testing those who are sick. So those are the two testing we are getting. So the data we are getting, you cannot call it community data. It's almost like hospital data. I know that with the data you're having, the people have some hope that things seem to be going down. But as my colleagues have said, you cannot depend on that unless you know what is happening in the community. We do not know how many people who are sick in the community, particularly in the rural areas, who actually don't even get to hospital and either recover and either die. So what I've been seeing is that the positivity rate seems to be going down, but the limitation is what I've said. But the death rates have remained the same, actually. We would expect that even if you are doing comprehensive testing, that the positivity rate will come down probably earlier than the death rates. But the limitation is the testing. I do not know whether it is the question of reagents or the question of capacity, or the question of a change of strategy. Maybe tomorrow we may have that information. We may have, our committee will be meeting with the ministry to get an update. We may have some information on that.
Right.
But I think it is too early to really think that things are improving. But let me also say something. I have the permit to move once in a while because of the nature of the work. We have to go to the rural areas and we have to come to committee meetings. And I wasn't quite impressed by the controls at the borders. So I'm not so sure that we are doing even very well in restricting movement. Maybe with the big public vehicles like buses and matatus, but with the small personal vehicles, it wasn't as strict as what we saw last year.
Right, and Professor,
I wanted to add something on this testing strategy issue. And you asked whether the strategy is right. And I asked myself, is there a strategy in the first place? You know, for one, if you are out of Nairobi, how available is the testing in the first place? Can I walk into a health facility and be tested? Secondly, if I'm poor and I can't pay for it, can I get tested? Who is actually getting tested? It's those who live in places with testing facilities. It is those who have money to pay for it. So the poor people, we don't know the positivity rate among the poor people, among the rural folk, among the nomadic tribes, among the slum communities. What we are seeing is positivity rate in the middle class and those who are in the upper class of society. But there is also general stigma around testing, which I've seen in some communities. People would rather hide, you know, sometimes than be tested so that they know their status, which is worrying because once you're tested, you know, you're isolated and people don't like to be isolated for 2 weeks. And if you're tested again, you need to be tested a second time to prove to people that now you are negative and you don't have that money. So we need a strategy basically, because I think it is more complicated than we are putting it.
Right, you say that it's not clear that we have any
something, maybe I can add something. There's something you said earlier that's also important. The issue of contact tracing. When people are doing voluntary testing, it means that really our contact tracing is not working. And you don't hear much about quarantine as we had before. Of course, it had its problems. And therefore, it means that isolation is just for those who are sick.
Right.
And those who are voluntarily tested and found that they are positive. And I don't even know how we monitor that isolation, particularly for those who have tested voluntarily.
Right. And Professor Osuru, because you listen to different stories coming from the different parts of the world, and they tell you that there is that shortage of testing reagents, or it was, especially at the start of the pandemic. You're still being told that it's still, what is the word? It's not as easily available as we may want. But then you wonder, when you look at these statistics, because when the president is making, or the government is making those decisions to revise measures of containment, they depend on these statistics that we are now saying are not representative of the truth. I'm just wondering how useful then it is, especially when you're going to deal with the rural populations, like you are saying that not many of them are getting these services of testing. Prof, can you hear me?
Testing centers and enough kits to do the tests. Yeah, I can hear you. Can you hear me?
Yes, go ahead.
All right. Yeah, I'm saying I wish we had enough testing centers and that we also had enough reagents to do the tests as required. You know, the original protocol, which is what works. Test, 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 trace, 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 isolate. That is what stops the disease from escalating. We are not able to do that. I wouldn't say the pressure on testing kits is as it was in the early days of the pandemic. The testing kits are now more available. But our strategy changed from free testing to testing for pay. And then it even changed further from contact tracing and testing to testing for those who appear in health facilities. So that strategy has made it very difficult to know what the statistics are. Of course, when those who are coming to the hospitals are positive, then the president has made the right decision because we are seeing high rates. But it could be the tip of the iceberg. It could be that these people are showing us what could be happening in the community. What, however, is that depending on which community you come from, it may not be the full truth. And we would have been better off if we had mass testing, isolation, contact tracing like we were doing before.
Right. Well, I asked that question because you see, for instance, at the moment there's the partial lockdown in the disease-infected zone, as it was referred to by the president. But you look at the proportion of testing, it's heavily in those 5 counties, and obviously also the positive cases. But Dr. Ngani, so you are at the very front line of critical care, and I remember visiting your facility sometime last week. But when people are getting tested because they have shown symptoms, maybe you can tell us about the difference in how the outcomes are, how the treatment regime is between appearing to before a facility for testing versus contact tracing, or what you may have called mass testing at the very start of the pandemic.
Thank you, Sam. Allow me to take this from a little bit far back, because I realize that for the professors and myself, maybe we are talking a little bit about scientific details without breaking it down quite a bit. And it's important for the public to understand why this issue of positivity rate is important, and whether the sample is from the community or is from hospitals. And essentially what it means when you do mass testing, if you were to do testing in the community, then we found a positivity rate of about 10%, then you can extrapolate that to mean that if you had to test everybody in the country, you'd expect about 10% of the population to have COVID-19. This is what it means, despite the fact that the COVID-19 test is not available to everybody. However, if the sampling is skewed, so that you're not testing everybody in the population generally, you're testing those who are actually sick, then you can get a much higher positivity rate. Then you have a rate like 26%, which doesn't necessarily mean that 26% of the country has COVID-19. For sure, these numbers that have been reported, the 176,000, is a very small proportion of those who've actually had COVID-19. And every single day when you have a number reported, it's important for the public to know that that is just a small sample size, and a bigger proportion of the population would have COVID-19. The second part that has been spoken about by Professor Nikala, and is super important as well, is the concept of contact tracing and isolation. Last year, if one had been exposed to somebody who had COVID-19, then they lock themselves out in their homes and stay there for about 10 to 14 days. And then thereafter, that is when they can go back to the community. And this way, we limit its spread. But what we are seeing now is a situation where, number one, relatives and friends insist on visiting people who have COVID-19, and it's a big fight between hospitals and relatives around visitation. And then those who know they've been exposed to someone with COVID-19 do not self-isolate. So they travel in public transport, they move around, the African way. We show we care by being there. Yet in fact, this caring, the fact that I don't have symptoms doesn't mean that I don't have COVID-19. Right. The fact that I've not been tested positive doesn't mean I don't have it. And so what we are seeing is that people who ought to be in isolation are actually moving about in public and thereby spreading, not by any ill intention, but just that lack of awareness. And therefore, I'll take this opportunity to request every single Kenyan that if you had been exposed, the correct thing ideally would have been to be in isolation. Right. That's for government to implement, but then for us as responsible citizens, for us to support each other and be in isolation. Now, is this effective? Definitely it is, because you may have COVID-19 without having any symptoms. And this is why contact tracing was important back then. However, in a season where we already have COVID in the community, then contact tracing in the strictest sense is not the biggest determinant of outcomes, but responsibility within our society. Because you see, you'd have COVID-19 almost 10% in a certain population. And therefore, for us to know that we can spread this disease to somebody else who may not make it.
Right. And I ask that question because you look at the fatality rate, it's increasing every single day. And the past 1 week I was doing my calculation, and you find that in the past 7 days up to yesterday, 124 fatalities were reported. So if you had to do the math, then 124 divided by 7, I'll give you the answer shortly. But if you are to look at that fatality rising, is there any correlation between when you report to a facility and the treatment regime you get versus initially when it was contact tracing or mass testing?
I'm not sure I'm getting your question right, but the question about treatment regimes, yes, there is a little bit more we are able to do as doctors right now, which could improve outcomes. There are some drugs that have now been approved by the PPB that we are able to utilize to a large population. Unfortunately, most of these are quite expensive, but these options really allow for good outcomes. Now, if you present to the facility early, your outcomes are much better. This is what we are seeing, because I'll give the example of a drug like remdesivir, which has been shown to, when you have severe disease, you can have, you can change the course of treatment, you can allow, the patient can be in hospital for a shorter period of time, and even the mortality benefit has been shown in multiple studies. And if you get this early, then your outcomes are slightly better compared to if you come late. I wanted to mention something about the mortality, the numbers we are seeing, and I have my own reservations. I feel they're highly conservative, and I know for some days they have not been representative. This is why I'm grateful to see the Ministry of Health reporting what are called audited deaths, which, deaths are not reported real time, but as time goes by, then they are into this, because what we are reporting is way too low. I know of a particular day where we had one death reported in the last 24 hours, yet that day a friend of mine had lost the mother, and I spoke to a facility that had the fourth mortality in the day they were looking for a bed for a certain patient. And so I know that we are grossly underreporting mortalities, but I'm glad the Ministry of Health has taken initiative to ensure that these are put together. And Sam, you're very right to be worried about that trend. When you're seeing this number of mortalities, then it begins to show you that there's a bigger issue. Then remember, there's a number of patients who are dying of COVID-19 who've not been tested, who've had samples taken, and those results have not been incorporated. Okay, they'll be incorporated later, and therefore the loop is not closed. And so it's a bigger issue. And what it's saying is that our handling of data isn't where it's supposed to be, though there are attempts to improve on this.
Okay, all right, I got the answer.
Maybe I can add something on the mortality. I think there's even another loop that is not actually included. You know, in the rural areas, there are people who actually get sick and die, and they actually just buried. And some of them may be dying of COVID. That data is completely not with us. It eludes us. Well, it's difficult also to get it, but there's something we could do at a community level. You know that all deaths are actually reported. So the chiefs and the assistant chiefs actually report all the deaths. Right. Another data that I think we could bring in is look at over this period, what are mortalities that are reported through that system. It would not be accurate, but you would also see a trend that as our mortality in the hospitals proven COVID is going up. What is happening in the community? Is the mortality also equally rising? There's something that would probably be more difficult, but we could still do, mainly at research level, Professor Sur and Dr. Ngani could do. There is verbal autopsy where if you have defined case definition, then those who get sick, but let me say those who die, you ask how did they get sick? Are there symptoms that you can say it's related to COVID? Right. Then you can all have a good idea. So we need a more comprehensive data, strict statistical data from hospitals, and even community data that can give us an indication of how the country is faring at large. Sometimes I think that when we get these horrific figures from other countries, maybe they have more accurate data than we have, so that we are thinking our mortalities are lower, but we are missing out on what is happening out in the community at large.
Right, and it appears we have such a big challenge. Just before you go, okay, Professor, so go ahead.
Yeah, I think all this relates really to the testing that we are talking about. You know, the definition of a COVID death Because for you to define a COVID death, you must have tested for it. And so the testing becomes still very key in defining how many people are actually dying. What some countries are now doing is to calculate the excess deaths, which I think Prof. Nikal has talked about.
Right.
Because we can estimate how many deaths we were expecting this year from previous statistics.
Right.
And then we can see what is the excess number of deaths we are seeing, and you can easily gauge how many people are actually dying from COVID. Without that, what we are seeing again is not really the truth. It is much worse out there.
Okay, very, very interesting perspectives there. I did the calculation, 124, it's an average of 17.7, so that's about 18 deaths reported on a daily basis. But Dr. Nikal, over the past few days, weeks, and actually months, we've seen different public offices closing down after a few cases have been reported, including some fatalities. It has happened to government ministries, to the judiciary, and now we are seeing that Isiolo County has shut down or closed all public offices apart from those that provide essential services for a whole month. When you look at these strategies, at a time that Laikipia County is reporting that they're overwhelmed in the Nanyuki and Nyahururu hospitals, is there something we're missing? Because when you close, you resolve for a little bit, then you open up, then you have more infections, you close again. What needs to be done in the longer run to be in a position to ensure that service delivery continues even as we battle the pandemic?
I think to a large extent, a lot of things depend on testing. You know, in those cases where they close those facilities, I don't have the facts on how they decide or to test all the stuff. But my strongest guess is probably somebody gets sick, somebody's diagnosed, then gets sick, goes for testing, it's found to have COVID, then they do the testing, and then they say, okay, we close. Now, then they give themselves time. I'm not so sure that when people come back, they're tested again. What we need is what Professor Sur said earlier. Do we have a testing strategy, which will also guide public institutions? You see, even Parliament now is closed, but again, we are closing because of the high numbers and the number of MPs that have been tested, and have tested positive, and some that have been sick. So again, one would presume that when we reopen, probably we would say, are we all going to get tested again before we open? So the summary of it, to guide everybody, is a strategy, a national strategy that is followed by all institutions at national level and at county level. Then you would have a clear guideline on what to do, when to close, and when to open.
Okay, all right. Yes, Dr. Ngani.
If I may jump into this one, I think part of what we are seeing as a country is that we are doing a little too little, and we are doing it a little too late. So that when you see the responses from many offices, it's sort of reactionary, waiting for someone to die, a few people to get COVID, for us to do what we ought to have done a few weeks ago. And the impact of that is that then these measures are more painful, they last for much longer, and a lot more people are affected. So it's important to understand when you see a trend starting, say, for example, in Nairobi, in Africa, we say, Wembe, ni ule ule if your colleague is being shaved, you prepare your head. So let us prepare and understand that COVID-19 is spreading in society and take measures early. And what are these measures for the county governments? Ensure that the hospitals are ready. Right now, we are doing the innovative ways to give service. It doesn't mean that the service providers or the offices should close permanently. Right now, we are doing sort of an interview via Skype. A few years ago, it would have been live on television. So these options exist, and for us to think out of the box. It's also perhaps necessary for us to understand that if we are prudent in what we are doing, then we don't overwhelm the health systems. The issue here is not people getting infected per se, but getting infected at rates that mean that we run out of ICU beds, we run out of oxygen, we run out of basic things that would otherwise have saved people who had either mild or moderate disease, or even those who had severe disease but had the chance of getting saved.
Right.
And then finally, there's a definitive thing that has happened in society now, and this is vaccination. The UK has seen a dramatic drop in the COVID-19 cases because they are probably one of the leading countries in vaccination. And the same trend is expected for Africa and Kenya. We're at about 400,000, which is slightly less than 1% of the population. But it's possible for us to ramp this up. And this will definitely change the picture. And therefore, the question of whether this is an endless journey where you open, people become sick, you close, people become better, there's an end to it, and that end, I believe, vaccination is a key component of that.
And that's our next topic after the break. But before we take that break, Professor Sur, you look at the severity of the disease. Dr. Ngani will tell you that it's getting worse. People needing more ventilation to be assisted with a ventilator, more people requiring oxygen. At the moment, from the statistics from the Ministry of Health, I hope they're accurate, they indicate that 513 people require oxygen because 256 are in ICU. And among these, I believe it's about 56 are on ventilator, then another 257 are under supplemental oxygen, whether it's in HD or general wards. So when you look at this at a time that the biggest referral hospital in the country, Kenyatta National Hospital, has had to cut down on non-emergency surgeries because of the situation with shortage of oxygen, what do you think is the best solution out of this? Because people need to live their lives and they need to live them in a healthy manner. What do you think can be done to sort out this challenge of oxygen at the moment?
Yeah, so I think it all ties up together with the whole strategy of how we manage COVID, because we are running out of facilities, out of oxygen, out of ICU beds, because the numbers are too high. And the numbers are too high because the rate of infection in communities is rising. And also, what we mentioned earlier, because we are not having a testing strategy, then you end up with people going, you know, if you have COVID, there are people who have gone to 3 health facilities seeking treatment for malaria, seeking treatment for migraine, for asthma, before they finally ended up very sick in a facility that can test for COVID. So they are coming late. And when they come late, then their chances of ending up in ICU are much higher. So, you know, the whole strategy around COVID needs to be relooked. But we also know there is, the virus is also getting clever. It is mutating. And when it mutates, it spreads faster. And there are many variants now which are circulating all over the place. I'm not even sure. Yesterday we were hearing in India now we even have a double variant, which is mutated more than once. So we don't even know which virus is causing too much infection in Kenya. So from all this, you see that it is a bigger overall strategy on how we look at COVID, the multifaceted approaches that will help us to decongest the health system. It is how we test, it is whether we are able to know the variants, it's how we isolate people, it's how we make sure they go to hospital early. So it's a whole strategy kind of overhaul that is needed. It is where we put our money. I don't know where the money is going now. Maybe Dr. Nikal will tell us. But where is the money going? Is it really targeting transmission or cutting the transmissions and so on? And even vaccination, we are not likely to see the results of vaccination in the near future. It may be, if we do very well, maybe 1 year because of the rate at which vaccination is happening and the deficiency for the vaccine across the world.
Okay.
So these are the things that have to be done. We need a really working strategy and an overhaul of what we have now.
Wow. It's unfortunate that 1 year into the pandemic, you're still talking about a strategy that appears not to be present or a strategy that appears to be weak. I want us to take a short break. On your return, we'll be talking about that particular topic about vaccination, the challenges that you're facing, what next for Kenya at a time that we hear there are already talks over J&J, the vaccination jab, because of the challenges in getting AstraZeneca after India made some statements there saying that they're going to limit exportation of what they have. We have that after the break.